Good day, everyone. Welcome to this latest webinar in our nutrition reporting series. As you know, this program is offered through a partnership of the International Center for Journalists and the Eleanor Cook Foundation. Today, we will focus on the urgency of investing in nutrition during this COVID-19 pandemic. Our speaker is Martha Nyagaya, Kenya Country Director for Nutrition International. She's able to drill down on some of the impacts of the pandemic on nutrition and some of the solutions for addressing those impacts. Your ICFJ team, once again, will include Taylor Dibbert and Paul Adipoju, our program managers, and of course, journalist and media trainer Mercedes Sayaguez, who will lead the conversation after the presentation. Now, let me turn over to Maria Borden of the Eleanor Cook Foundation, who will introduce our speaker today. Maria.
Thank you, Jerry. Hello, everyone. It's a pleasure to be with you all today. My name is Maria Borden, Corporate Communications Officer with the Eleanor Cook Foundation. You may have already heard from our CEO, Will Moore, during the beginning of the webinar series, but we at ECF are a growing U.S. philanthropy fighting to end global malnutrition through research, policy analysis, and advocacy. I am thrilled to be with you all today to introduce our speaker, Martha Nyagaya. She is Nutrition International's Kenya Country Director, as well as the chair of Scaling Up Nutrition Civil Society Alliance. With Nutrition International, she leads program planning and development at the country level and manages relations with Kenya's government and other key local stakeholders. And with Scaling Up Nutrition, she convenes partner meetings and facilitates the implementation of multisectoral nutrition actions to ensure that Nutrition International program activities are in step with others and with partners. She brings over 15 years of experience working in sub-Saharan Africa in a range of programs, including food security, nutrition, health, and HIV/AIDS. Without further ado, I am turning it over to Martha. Martha?
Good morning, good afternoon, good evening, everybody. Welcome to this session, and I am going to take you through some tips on the urgency of investing in nutrition amid the COVID-19 pandemic. And this presentation is a consolidation of a number of studies as well as data that is coming from different sources that will give you an impression of why nutrition is urgent, why investing is urgent now, and the general situation of malnutrition globally and in specific spotlights where it is really right now a bad situation. Next slide, please. So just to give you a quick briefing on who NI is, we are a global nutrition organization headquartered in Canada, and we have in more than 60 countries, primarily in Asia and Africa. And we do have offices in the places that are shown in the map, 13 offices in 11 countries. We have over 600 people worldwide. We provide technical assistance in over 20 countries. We also have programming in 60 counties, and we have global advocacy campaigns. Our vision is to see a world where everyone everywhere is free from malnutrition and can be able to reach their full potential. And we do this through transforming the lives of vulnerable people, especially women, adolescent girls, and children, by improving their nutrition status and delivering proven nutrition interventions to those who need them most. We also do nutrition research, policy formulation, advocacy for prioritization of multisectoral nutrition programs, and integration of nutrition into broader development programs. Next slide. So for the purpose of this presentation, we will focus on the causes and effects of undernutrition, particularly in the global south, and I will also provide some insights into some interventions that we can explore to make the situation better. Next, please. So 1 in 3 people worldwide are malnourished. In 2020, globally, as highlighted in the Global Nutrition Report, we have 149 million children under the age of 5 years who are stunted. This means that they're not only too short for their ages, but this has also affected their brain development. And if this is not corrected within pregnancy to the 2-year age of the child, then this is irreparable damage. We also have 45.4 million wasted children and 38.9 million people in the world who are overweight. What this situation reflects is that the world has the triple burden of malnutrition. And whichever way you look at the world, malnutrition affects all countries. 45% of the countries are really undernourished, while the remaining percentage have the coexistence of over and undernutrition. Today, 1 in every 9 people in the world is hungry, and 1 in every 3 is overweight or obese. More and more countries are experiencing what we call the double or the triple burden of malnutrition, where undernutrition coexists with overweight, obesity, and other diet-related non-communicable diseases. Almost a quarter of all children under 5 years of age are stunted. And at the same time, overweight and obesity are increasingly and rapidly in nearly every country in the world, with no signs of slowing. So something needs to be done to address this issue in whichever country and depending on the burden that we see in those countries, with contextually appropriate interventions given the types of manifestation of malnutrition we're seeing. Next slide, please. So we have overlapping forms of stunting in children under 5, anemia among women of reproductive age, and overweight in the adult population. The prevalence and percentages and the thresholds used to determine whether a country is experiencing a high prevalence for any given form of malnutrition, be it stunting, be it anemia, we have used in this global nutrition report, 20% and above. And as you can see, based on the latest data, if you look at these maps, based on the latest data available for about 143 countries, Africa has a high prevalence in overlapping forms of overweight, and particularly in urban areas, anemia and stunting. If you look at the North American region and parts of the South American, overweight is the biggest burden. Of the 143 countries represented in this map, 124 are experiencing a high level of at least 2 forms of malnutrition. So with 56 countries having anemia and overweight, 28 countries anemia and stunting, 3 countries overweight and stunting, we are seeing that only 19 countries experience high levels of just 1 form of undernutrition. So we must see this in multiple dimensions, and we must see this as a triple burden of malnutrition, predominantly driven by diets and food consumption patterns. Next slide, please. So we also see significant inequalities in nutrition outcomes within countries and populations, with at least 5 sub-regions having stunting rates that exceed 30%. Next slide. So we can look at these maps to understand the prevalences of the various nutrition issues, but the most alarming one is that 15% of the world's stunted children are in East and Southern African countries. And if you look at the data from those countries, progress on stunting has almost halted. 27 million children under 5 are stunted within the region, and this is a number that hasn't changed in the last 5 years. At the same time, the rates of stunting are concentrated in only 10 countries, where 84% of all children, 84% of all stunted children are in these 10 countries, including Tanzania, Rwanda, Uganda, Malawi, Ethiopia, Lesotho, Zambia, and Kenya. Next slide, please. So as we look at these maps, we also see that wasting in Southeast Asia is quite high. And we also see that in the Southeast Asian region, the main problem is actually inadequate food intake over short durations that lead to really children having very low weight for their ages and needing immediate food interventions rather than long-term interventions. And if combined, then these interventions will be very useful in the long term to address the recurrent wasting problem in this region. Next slide, please. So what is causing malnutrition in these regions? I think child undernutrition is caused not just by the lack of adequate nutritious foods, but also by frequent illness, poor care practices, and lack of access to health and social services. If you look at the bottom line, which indicates that the immediate causes of malnutrition is disease and inadequate care, and in this situation, healthcare, then it means that these multifactorial determinants outlined by UNICEF more than 20 years ago are still the main drivers of undernutrition. For example, if a child has diarrhea, they will, for a long period, they will immediately lose weight and become undernourished. At the same time, if a child does not have access to healthcare to treat the diarrhea, they will still get the repercussions of this. And so these causes are very immediate. It takes 1 to 2 weeks for a child to get malnourished as a result of these immediate causes that are then affected by underlying factors. So the immediate causes of undernutrition are inadequate dietary intake and disease. A child's dietary intake and exposure to disease are affected by what we have in the column of underlying factors, including household food security, lack of availability of access to health care, lack of availability of food, utilization of a diverse diet, inadequate care and feeding practices for the children. For example, when a mother does not have access to healthcare, does not appropriately breastfeed the baby, unhealthy household surrounding an environment which will lead to diseases such as malaria or diarrhea, and inaccessible and often inadequate healthcare. So even just the example of HIV disease would cause immediate undernutrition. So in the first immediate column, we have disease and diet. And then this is affected by the underlying causes. And most of the interventions for the immediate causes of undernutrition are related to the healthcare system and the community support systems to enable a mother feed the child properly, to treat diseases, to clean the environment. And the basic causes of poor nutrition encompass the societal structures, the processes that neglect human rights, poverty issues, and the issues that perpetuate poverty, and limiting or denying the access of vulnerable populations to essential resources. So socioeconomic and political factors can have long-term influence on maternal and child nutrition. So this conceptual framework for nutrition gives us the multitude of issues that lead to undernutrition in children, in women, and in the normal society. So what is our key message using this conceptual framework for nutrition? That nutrition is multidimensional. It leads to poor health. It's associated with lack of education. It is associated with inadequate living standards, poverty, lack of income, disempowerment, there are so many underlying and basic causes that drive the immediate causes of undernutrition. And the underlying causes are embedded in people's social, economic, environmental, and sometimes political positions in society. So people are poor because of who they are, where they live, what their government systems are. But those things cannot be addressed with one program. If we fix the food systems, what about the health systems? What about the water and sanitation systems? What about the environment that people live? So chronic poverty in many cases is intergenerational. It can change over time. But all these factors are interrelated and interdependent. And in some situations, they are reinforced by shocks and stresses, such as the COVID-19 pandemic, such as conflict and humanitarian situation. And this then forces people into patterns of behavior that entrench poverty and move malnutrition in different forms. Next slide, please. So the effects of malnutrition are felt across every area of life and across generations. In fact, at Nutrition International, we say we make the difference because nutrition is the difference. It's the difference between giving birth to a child and giving that child life. It is the difference between taking a child to school and enabling that child to learn. It is also the difference between fighting a disease and surviving it, or getting a disease or preventing yourself from getting a disease. So malnutrition has an effect on education, malnutrition has an effect on economic development, on gender equality, on immunity and resilience. And on health particularly, low immunity, poor child growth leads to high demand for healthcare services. And therefore, the cost of not addressing malnutrition is included in the burden that it puts on the healthcare system. On education particularly, we have seen that stunted children have a low IQ, they perform poorly, there's increased absenteeism and repetition of classes because the child is either not well nourished, has a poor immune status. And so that is how all these things are interdependent. And according to the World Bank, or even the cost of hunger studies conducted in different parts of the world, the economic impact of undernutrition in the education sector alone is about 0.6% of GDP, and stunted workers are less productive than non-stunted workers. Every dollar invested has the potential to result into $22 in economic returns in Kenya alone, where World Bank conducted a study looking at the impact of nutrition on the economic situation of the country. Next slide, please. As I speak about gender issues also, that women eat last and eat least in most of our society. And in Western Kenya, where I come from, we still have rules around even just basic things like parts of the chicken that a woman is allowed to eat. The more fleshy parts are left for the men. The drumsticks, as a woman, I cannot touch the drumsticks. I'm only allowed to eat the back and the wings. And so there are gender inequities that really drive undernutrition because they are culturally ingrained and they prohibit specific people in the population from getting the right foods. So what exactly are we saying? We are saying investments in nutrition are in now in the context of COVID-19. We had that situation before the COVID-19 pandemic, and the investments in nutrition will become even more critical in the medium term. So we know, for example, that COVID-19 sorry, I'm trying to put the full screen, that COVID-19 is exacerbating high pre-existing rates of malnutrition, with over 1 billion people globally malnourished prior to COVID-19. The pandemic has made more people malnourished and put millions of vulnerable people at risk. And we will not know for sure how many people these are. We cannot know the exact impact of COVID-19 right now, and we will see this impact many, many more years to come. If COVID impacts on nutrition are left unchecked, the health and well-being of millions of the world's most vulnerable people will be compromised, and the hard-won development gains of the past decade will be lost. So nutrition can't wait. The pandemic is risking essential services, and many key interventions just can't wait. Nutrition must be central across our response plans, across our resilience building plans, and across the recovery phase of COVID-19. And we cannot wait for treatment. We must focus on prevention as well, and focus and invest on prevention now. Next, please. So the impact of COVID-19 on nutrition is actually felt across the board. This is a health crisis that is leading to an economic crisis, that is leading to a diet quality crisis and a service delivery crisis that then translates to a malnutrition crisis. COVID-19 is straining the healthcare system and forcing governments to shut down economies. This is leading to an economic crisis. Trade stops, incomes fall, asset prices collapse, and government revenue shrinks. What happens with families? Families cannot afford, and they now have less access to nutritious foods, and so diet quality falls. Service delivery has also fallen because the fiscal space shrinks, health budgets contract, while most governments use already constrained health budgets to respond to COVID-19 treatment processes, and government gets conflicting advice, and nutrition services are scaled back because of prioritization of COVID-19 treatment processes. And so what we are seeing is a crisis that is building, that if left unchecked will be bigger than what we are currently seeing in the near future. Next slide, please. So we also know that COVID-19 crisis will discriminate particularly against women and girls. In Kenya, for example, in some counties, we are seeing up to 42% of girls not going back to school because of unwanted pregnancies and because they have been out of school for too long. These are children getting pregnant. Their body structure and systems are not yet ready to deliver healthy babies. We need to intervene now. Women and girls face significant pre-existing vulnerabilities due to malnutrition. Women will continue to eat least and last. Women's health and well-being is often the first to be sacrificed as incomes fall, because as governments get the limited budgets to address the COVID-19 pandemic, we need to ensure that maternal, child health, and delivery practices are also prioritized in the context. The burden of care will fall disproportionately on women, both in the household and in their roles as caregivers and as community health workers. Girls' school attendance is also expected to fall, and for child marriages to increase. And we are already seeing signals of that as a result of school closure, as a result of the economic pressures that families are feeling, and also an increase in gender-based violence because people are staying at home, they are on each other's faces all the time. And because of the hard economic times, as well as the fear of the pandemic, as well as the fear of the full healthcare systems, people are easily aggravated to conflict. And in Kenya, Uganda, and parts of Malawi, we have seen a rise in conflicts at household level, particularly affecting women. Next slide, please. So the stakes could not be higher, and the need cannot be more urgent. According to FAO and some of the data we are getting from the World Bank and World Food Program, we can see that already there are signs of danger. The economic costs and consequences of the pandemic are quite severe. Up to 80 million people from FAO data may become malnourished because of the economic impact of the pandemic. The number of people suffering from acute food security could also double to 270 million, given very specific data from World Food Program. Other organizations under the Research Square Forum are making additional prediction. And if inaction is not an option, without immediate action by 2022, we will see up to 2.1 million more anemic pregnant women because of health systems shutting down, because we are not getting these women early, because of travel restrictions, and also because of hard economic times. 9.3 million more children suffering from wasting, again because of hard economic times, because the food systems have been affected by this pandemic. An additional 2.6 million more children suffering from stunting as a result, and 168,000 deaths of children under 5 years old as a result of mainly the immediate causes of undernutrition I mentioned, which is disease and inaccess to food, or lack of access to food. Next slide, please. So what are the priority actions in this context? We know that the odds of dying from the 4 most common infectious diseases, even without the COVID-19 pandemic, diarrhea, pneumonia, measles, malaria, increased significantly with the level of malnutrition. A wasted child will be 9 times more likely to die from these 4 causes combined. A stunted child is 4 times more likely to die. So we know that malnutrition is one of the largest contributors of weak immune systems. And we have seen from recent findings that if you are overweight and obese, then the risk of dying from COVID-19 increases. If you are underweight or undernourished, then you have a weak immune system and your chances of getting the disease increases and your chances of recovery reduces. So malnutrition already costs the global economy about 3.5 trillion through multiple channels, such as the less productive systems. However, in the context of COVID-19, there are a number of priority actions that have been identified by various groups. The first one is to continue to deliver high-impact, low-cost nutrition interventions with a focus on women, children, and girls. And these interventions include particularly interventions in the first 1,000 days of a child's life, from pregnancy to delivery. And in our response and recovery plans, we are encouraging governments to ensure that these interventions are included as part of the response plan and as priority interventions. The second one is to make nutrition a pillar of every phase of the COVID-19 response and recovery plans. There are people who need food now, there are people who will continue to need food, but we need to build resilient systems that will make the health and food systems be able to handle these pandemics now and in future. The third one is integrating nutrition into non-nutrition platforms and sectors, such as education and WASH, because we have seen that the underlying causes of malnutrition lie in these sectors. If we do not hand wash and continue with hygiene beyond the COVID-19 pandemic, we will still see the increased occurrence and prevalence of diseases. The fourth one is to ensure food systems work for nutrition, to ensure that the social protection programs are targeting the most vulnerable and are most appropriate in that context, to ensure that nutrition works together to improve diets and the health systems and the food production systems work together to address this issue multisectorally and in a coordinated manner. And the last one is to increase global visibility and investments in nutrition, and particularly on food systems, because there were many questions coming in on the food systems thing. Just to allow me to highlight a bit, Jerry, in a few seconds, is that food systems shape diet quality. And the systems include the agricultural production subsystem, the food storage and transport and trade subsystems, and the food transformation subsystems, as well as the food retail and provisioning subsystem. So the food environment has all these systems. So food production alone does not automatically translate to good nutrition. The food environment will determine the consumer choices, the consumer preferences, the time they have available to prepare food, the knowledge they have on what foods to buy or prepare, as well as their economic and purchasing power. So let us look at this component in a very holistic way, because if food systems are not working hard enough to improve nutrition, then this will affect the choices of nutritious foods. Nutritious foods will be less available, and there will be too much food lost in storage and transportation given the travel restrictions. And food transformation systems may also transport foods into maybe not healthy foods, such as adding more salt, adding more sugar, less fiber, and so the foods then will become less nutritious in the context that we work and in addressing the food systems issues associated with the COVID-19 pandemic. Next slide, please. So during the preparation of these slides, I was asked to present a bit of what we call proven solutions, which are low cost, high impact interventions, as well as an example of what has worked. So in the next few slides, I would want to explain a program that we do in Kenya. Next slide, Paul. Because COVID-19 does not treat us all equally, and undernourished people having weaker immune systems with the numbers of undernourished people that I've mentioned may be at greater risk of severe illness due to the virus. At the same time, obesity, diabetes, non-communicable diseases are strongly linked to worse outcomes of COVID-19, including the risk of hospitalization. So in the context that we work, we know that there are proven high impact, low cost interventions that can make a difference. Immediately, vitamin A supplementation for children under 5 alone will lead to 12 and 24% reduction in the risk of all cause of mortality. 15% reduction in incidence of diarrhea and 50% reduction in incidence of measles. Zinc and ORS, which is just a co-pack for treating diarrhea, will lead to 23% reduction in the risk of child mortality. Iron and folic acid supplementation, and I would like to make this very clear, pregnant women are pregnant now during the pandemic. We cannot wait to grow food, for example, for them to eat in future to reduce anemia. So we need, again, immediate interventions for immediate causes and long-term interventions for underlying and basic causes to build resilience and recovery plan. Immediately, if we could provide iron and folic acid for pregnant women, we will see 67% reduction in the risk of anemia, as well as reduced mortality, and a 19% reduction in the birth outcome, which is measured through low birth weight. Exclusive breastfeeding alone, which is free, which is available for the child, All we need to do is behavior change interventions, as well as train the mother on appropriate breastfeeding practices, will lead to 31% reduction in infant mortality. And in many countries, we are seeing up to 40% of children not being breastfed appropriately because the mother either does not know the benefits of breastfeeding, or is not breastfeeding appropriately, or is starting giving complementary foods earlier than 6 months. So some of these interventions are very low cost, but very high impact. And what we need immediately is to reduce mortality associated with some of these repercussions of the pandemic. Food fortification alone, and if we choose appropriate vehicles, will lead to 24% reduction in risk of anemia among women. And these are interventions that are not just proven, but can be implemented at scale and are very cost effective. Next slide, please. So in this slide, I would like to give you an example of what we are doing in Kenya. Selecting one intervention for a specific target group will not help us address the problem in the way that we need to address this problem. So in Kenya, for example, our approach is to select multisectoral interventions and engage deeply at subnational level on planning, not just implementation through parallel structures and NGO forums, but implementation of multisectoral nutrition actions. And this is how we have set up a truly sustainable multisectoral nutrition program. Paul, could you just go back to the previous slide so that I can explain a bit more before I come to this? So what we have done in Kenya is to support a national nutrition action plan. This action plan is not just a plan that determines which intervention should be included. It identifies specific multisectoral interventions across sectors. What should agriculture do? What should health do? What should gender and community development do? What can we do in the education sector with school-going children? So this is an overarching strategy that determines and responds to most of the questions that the various sectors have been asking. What about nutrition should we do? It is not just an identification of interventions. It is costed. It has a results monitoring framework. It has a coordination framework for the various sectors. And it is also a resource mobilization plan. So in Kenya, we take advantage of the devolution of government structures to the subnational level, which we call counties. So drawing from the national action plan, we have developed county nutrition action plans now in 20 out of 47 counties. And that subnational level action plan now draws out interventions from the national plan that are contextually feasible and appropriate for that county. Then we move on to the next step, which is developing an investment case for nutrition to inform the devolved government system to invest money in their own action plan. So we supported advocacy efforts with governors, with members of the county assembly, and we have been able to secure at least $4.9 million above baseline for the implementation of these plans. So we have, for the first time at subnational level, signed new performance-based matched funding agreements, not only to implement nutrition programs owned and aligned with government plans, but also to increase resources for nutrition in ways that are sustainable and in ways that beyond the program duration, the programs will continue and the action plans will continue to be implemented. We implement while we simultaneously build capacities of government in planning and budgeting for nutrition across sectors by just lifting interventions that are costed from the action plan and placing them in their annual plans and ring-fencing the money they have committed to be specifically used for nutrition. Next slide, please. So this is, I think, the second last slide. So in doing this, we have developed a truly multisectoral nutrition program, the previous one, Paul, that addresses the immediate causes, the underlying causes, and the basic causes of malnutrition across various sectors. So this is the first ever performance-based match funding model, not only to increase resources available for nutrition, but expand coverage of interventions across sectors, while simultaneously building government capacity to continuously finance and implement cost-effective nutrition interventions. The objective is not only to mobilize additional resources. From the NI perspective, we must be able to see not just more money for nutrition, but more nutrition for the money. And we are already seeing this from the results that we are seeing only after 1 year of implementing this program. Next slide, please. So what is significant about this program and why am I sharing it with you? Because one single intervention will not address a multisectoral, multifaceted problem. We have established baseline funding for key nutrition interventions. We have put in place systems that will allow us to track not only progress, but also financing for nutrition from domestic coffers. And we have also reduced transactional costs and committed to a multi-year joint work plan that is owned by the counties and is embedded in county policy documents. So why is this model important? It supports the implementation of multisectoral actions at scale. It ensures county and country ownership and financial sustainability. It provides predictability because the action plans are for 3 years. We are funding for 3 years, and we will expect that counties will proceed with their commitments beyond the program duration, fostering sustainability. It also ensures that additional domestic resources are provided for nutrition in a consistent manner, and it builds confidence, and the model can be replicated. So it is involvement of not just the Department of Health, but stakeholders from finance, agriculture, education, and all the sectors I have mentioned in the immediate, basic, and underlying causes of malnutrition. Next slide, please. So we can get more information from Nutrition International. We know that the context is quite dynamic. We have new data on programs. I have shared some links. We have seen improvements in the past, given the multisectoral nature of interventions that we provide. For example, in Peru, we have seen a reduction in stunting under 5 children from 31% in 2000 to 13% in 2016. It is possible to do this also in the rest of the countries that are suffering the different manifestations of undernutrition. But first, we must address the inequities in food systems from production to consumption, as well as the ones in the health systems. Next slide, please. So that is the end of my presentation. We have additional information for the journalists, and we have also included some of the links to the information that I've provided, which you can use for your writings now and in future. Thank you very much.
Thank you, Martha. Thank you for this masterclass in undernutrition, and also for the passion in conveying the urgency of addressing this problem, not only for this generation of children, but for future generations, since the consequences of stunting and malnutrition can take over a couple of generations. The questions have been coming fast and furious. I am happy to say that we can go beyond the limit for 15 minutes. Martha has agreed very kindly to give us 15 more minutes of her time. So we have about half an hour for questions. But before that, I want to go back to the poll that we did in the last webinar, which we couldn't comment because we were cut off at the time sharp, at 4 p.m. sharp. So Paul is now sharing the screen, and I'm going to ask Martha to comment briefly on these interventions. There was no right or wrong answer. We wanted to know where you were thinking. The winner was reform the farm to fork system or the agri-food system with 60%. And second was government to set the price of basic nutritious foods with 20%. Basic income grant had 10% of the votes, and the vouchers for nutritious food and unconditional cash transfers had 5%. So over to you, Martha, for an analysis of these interventions.
Thank you, Mercedes. And as you have correctly said, there's no right or wrong answers. All these interventions are important in the context of COVID and for reducing malnutrition. However, we have to look at the context in which we work. Reforming the farm to fork or reforming the food systems is a very important intervention for the long time. Because of the economic repercussions of undernutrition, and in most of the urban areas in Africa, where people live on a daily wage, and that is where they get their foods, and those places have been shut down, then we cannot wait to reform the agri-food systems to get food to those people. So while this is an important recovery and resilience building plan, it is not an immediate intervention. Vouchers for nutritious foods or unconditional cash transfers may be more appropriate in contexts like that. But again, vouchers for nutritious foods may only work where we already have nutritious foods in the market and where the transportation and food provisioning systems have not been disrupted. As well as unconditional cash transfers. You cannot eat money, you need the food if you have the cash. So if you are in the semi-arid and arid areas of northern Kenya or Uganda, where food availability and access is a problem, then unconditional cash transfers will not work. We will need food transfers or social protection programs that are protective and preventive that include food distribution. Government setting the price of basic nutritious foods will be essential now, but also in the long term, again, depending on how this is established. By and large, for communities that need food now, we need to determine the best tool based on the context as well as the vulnerability of the target population.
Thank you, Martha. And it's many different pieces of a puzzle that have to fit together. And as you say, context is key in order to determine which interventions should be now or tomorrow. So let's go to some questions. We have Lori Browner ready with a question. Lori?
Hi. On my phone. I saved it from yesterday. Thank you so much for this presentation. How can we ensure that the food supply remains stable for pregnant women and children while also educating women about the benefits of breastfeeding and avoiding mixed messages from corporations such as formula manufacturers?
Thanks, Lori. So ensuring that the food supply remains stable. One of the things that we can do is ensure that food systems work for nutrition. And whatever prevention measures we are putting, whatever prohibitions we are putting in a bid to contain COVID-19, food must be part of the plan. Food delivery systems, food storage systems, food provisioning systems must be part of the plan, particularly for pregnant women. In over 30 countries in sub-Saharan Africa, there are recommendations for ensuring that pregnant women get the adequate diet that they need, and particularly combating anemia because it leads to an increased maternal and child mortality during delivery. When we are prioritizing essential commodities during this pandemic, we have to ensure that essential nutrition and health commodities, specifically targeting pregnant women and children, are included. And this includes iron and folic acid supplements that pregnant women may need now, prioritization of hospital delivery for women as part of the package for priority interventions during this pandemic. On protecting breastfeeding, in many African countries, actually in over 60 countries in the SUN CSN network globally, we have promoted the code of marketing breast milk substitutes. And that code prohibits health centers, hospitals, delivery facilities from marketing breast milk substitutes, except when the child needs it for other reasons. Then it can be provided on doctors' recommendations. So to protect breastfeeding, we have the baby-friendly community initiative in most of the East African region, where we promote breastfeeding not just immediately after the mother gives birth to the child, but following that mother beyond the health facility, to develop community support systems such as mother-to-mother and father-to-father support groups at community level that will encourage the mother to continue to breastfeed exclusively for at least 6 months. And to address your question on harmonization of information, there are several tools and job aids that have been developed for community health workers to do home visits and to train women on how to appropriately breastfeed. In urban areas particularly, we have seen young mothers who do not want to breastfeed because they are afraid their breasts will fall. So there are also cultural things associated with breastfeeding that are included in those job aids and messages.
Thank you.
I think I will stop there.
Yes, thank you. We have Shreya Raman from India with a question about micronutrients. Shreya?
Hi, am I audible?
Yes, you are.
Thank you, Martha, for that insightful presentation. So my question is basically, since the midday meals in schools have stopped, the government has been providing basic rations, including rice and some pulses, but children have largely stopped eating vegetables or getting the other supplements like iron folic acids, like you mentioned. So my question is, how grave is the issue of micronutrient deficiency? Given the current situation, should we just focus on ensuring that children don't go hungry, or should we also ensure that they get nutritious food?
I think the issue of micronutrient deficiency is a very big issue. And if you look at the global burden of malnutrition, it is the box that has so many people, up to 2 billion people in the world by 2016, and the Global Nutrition Report this year reduces it a little bit. But most of the global burden of disease and risk factors are linked to diet. In fact, just a large percentage of children who have micronutrient malnutrition is because of inadequate dietary intake, particularly during the complementary feeding period when they stop breastfeeding. There are several interventions that many governments have put in place to address micronutrient malnutrition. If a child is having recurrent malaria or episodes of diarrhea and gets, for example, malnourished, it is very likely that this child is not just losing weight, but is also losing micronutrients. And so promoting a diversified diet is the best approach. In situations where we do not have access to diversified foods, then what we recommend is micronutrient supplementation. For example, the vitamin A supplementation, the iron and folic acid supplementation, in some cases, micronutrient powders that are sprinkled in children's food. We have also seen very recent dietary related interventions such as biofortification and vegetable production. In parts of Kenya, Uganda, and Tanzania, we have seen micronutrient deficiencies in areas that produce a lot of fruits and vegetables. So two things: trade-off between production for consumption and marketing of these products, and cooking methods for particularly vegetables. In Western Kenya, where we have so much vegetable production, for example, the vegetables are cooked to death. The boiling of sukuma wiki alone removes all the nutrients, and what the child eventually eats is roughage. So it's really a range of interventions that can be explored depending again on the context. Food fortification is another cost-effective one. What is the most popularly consumed food in India, for example? Wheat. What micronutrients can the government add to wheat to ensure that poor populations can access micronutrients even when they don't have them in the diet? So again, it's very context specific. It depends on what is driving micronutrient malnutrition in the context that you are. But by and large, the interventions include food fortification, biofortification, dietary diversification, cooking methods and techniques, as well as behavior change interventions around food consumption.
Thank you. Then back to Africa, Rafael Meningue from Malawi has a question about obesity. Rafael,
yes,
go ahead.
My question is, with COVID-19 crisis, most governments are now investing much in their health systems with little on nutrition in particular. How is this impacting on nutrition? You have already said.
Now, Rafael, as I mentioned, we need a multi-sectoral approach to nutrition. And we must start looking at the health systems and the food systems together. If you go back to the slide where I was looking at the causes of malnutrition, the immediate causes is disease and access to food. So with the COVID-19 pandemic, my understanding is that the governments are preparing the health systems to deal with the pandemic and to treat the pandemic, to treat the people who are already infected with COVID-19. In the context of our response and recovery plans, we must make sure that food is considered, that the food systems are considered, and that basic healthcare provision is not forgotten. Why? Because this is a health crisis that has led into an economic crisis, and that is leading to a food and diet crisis. And so we must look at all those boxes together rather than look at one box, the health system. One of the things that African governments need to do is to allocate a small percentage of the budget, where feasible, to preventive healthcare, because most of our health budgets are going to curative and rehabilitative healthcare. If we use some of this money for prevention measures of COVID-19, which are much cheaper than treatment, then we will be able to reduce the numbers as well as reduce the economic impacts of the pandemic. I hope that answers your question, Rafael.
Thank you. And now we go to Leda Balbino from Brazil. She is now ready.
Yeah, thank you. And thank you for the great presentation. My question is, you gave some examples about gender norms and practice related that can lead to malnutrition, specific about Kenya and about breastfeeding. But I'm curious about, could you give more examples of specific countries when gender issues lead to malnutrition?
Now, there's a huge relationship between gender and nutrition. And it's really related to the role of women in food and health. So at household level, in most of Africa and Asia, women work in the farm, isn't it? But in patriarchal societies, they do not decide what's being planted. They do not decide how much of what is planted gets sold. They do not decide what's being cooked at the household level. I will give you a few examples. I visited a household in northern Uganda in the Lira region, and I found a woman grinding millet on 2 stones. It is time consuming, it is labor intensive. She is pregnant. By the time she finishes doing this, she has to cook for the household. She does not have time for herself. She does not have resting time as a pregnant woman. And all these things affect her well-being and nutrition status. At the end of the day, she said she was grinding this millet manually because that is what the husband prefers. So look at the person who is deciding what's being eaten at household level and yet not even participating in the cooking. We have also, and that kind of food is not just nutritious, it is not appropriate for a pregnant woman and a child who is 3 years old who is in the household. It will fill the stomach, but it will not provide the nutrients that they need. In some cases, we have seen culturally ingrained gender inequities around intra-household food distribution. I said in my culture, for example, I'm prohibited from eating some very nutritious foods. I can now eat them because I'm in Nairobi. But when I go home and I'm serving my family, when a chicken is cooked, I can only eat the wings and the back, and the drumstick and the fleshy parts of meat belong to the man. So there are those culturally ingrained gender inequities that prohibit women from getting the right foods or even an appropriate portion of food. And while women cook and serve food, they eat last and they eat what is left over in many societies. On breastfeeding particularly, a woman who will grind millet for 3 hours, go and collect water for another 2 hours, work in the farm for another 2 hours, may not have time to breastfeed her child appropriately and on demand. So it has immediate effects on the child and again, effects on the woman herself. And even if we don't talk about time and workload, if she does not eat properly, then she will not have sufficient breast milk to give the child. As well as young women in urban areas are afraid of breastfeeding because of the shape the breast takes after breastfeeding. And so we need behavior change interventions such as breast will fall anyway at some age. So if you have a child, let them get the benefit of breastfeeding.
Thank you. We have Haitham Al-Crowd is ready now. So Haitham first.
Yes. Yes. First of all, let me thank you for this opportunity. What I need to ask your guests, I mean, the developing countries like Syria, Yemen, and Iraq. In these countries, what are the procedures or the policies to limit the lack of food in these countries? As you know, these countries are experiencing civil war and many crises in these countries. In this situation, what we gonna to talk and tell the public about this issue?
I'm afraid I have not clear information about the policies in place in those countries, but I think the generic recommendations for countries that are suffering from certain policy issues, there are a number of things that they can do to fix the food system. The first one would be to build demand for nutritious foods, like use hybrids of public and private approaches. I went to a very rural village in DRC, in the middle of DRC, where for 2 hours we had to go on a boat. And I found Coca-Cola there. And they know what it is and they drink it. So the private sector uses very powerful emotional and aspirational messages to market their products, and the product will distribute itself. The public sector must rely on logical linear health messaging, which may not work. So we need to change the way we talk about nutritious foods and create demand for nutritious foods with more effective public campaigns, contributing with marketing techniques that appeal to aspiration, emotion, and desire, incentives for consumers to purchase more of certain foods and less of others, or things like taxes on foods that are best avoided, or subsidies on foods that are the best nutrition choices, things like that will help make nutritious foods more available and affordable, as well as enabling environment, governments, and businesses to do more positive things for nutrition and make it harder to do the wrong things. So I think those 3 points are quite generic that will build demand for nutritious foods, make nutritious foods more available and affordable, and create an enabling environment for businesses and governments to provide more nutritious foods while we protect the consumer and build the food systems, as I had previously mentioned.
Thank you. Now we go to Karen Coates. Karen?
Hi. Yeah, thank you so much for this opportunity and this really informative presentation. Given the dire predictions regarding malnutrition during and post-COVID, I'm wondering what you think the broader long-term effects could be on society overall. And I'm especially interested in the effects of malnutrition on cognitive development across future generations.
As we have seen, the prevalence of malnutrition before COVID-19 is already so much. We have also seen that predictions are about a half more of already malnourished people being malnourished. So what we envisage is a situation, and that is only if left unchecked. Let's be very careful how we put it. If left unchecked, if we have more stunted children, for example, and these are children that have had prolonged inadequate dietary intake, especially in the first 1,000 days of their lives, they will become stunted. And stunting is not just a child who is short for their age, it has an effect on brain development. And if we don't intervene now, within the first 1,000 days, it's irreparable damage. So what we will see is more children with brain damage, more children who are too short for their ages, growing into adolescents who cannot go to school properly, who cannot pay attention in school, growing into adults who cannot work full-time or who have weak immune systems. And so it's really an interrelated and interconnected situation of things affecting things as the child grows, and a generation of people who will not be economically empowered to build the GDPs in their countries. So we will not just see stunted children, we will see the impacts on education, we will see the impacts on healthcare, where we will see increased occurrence of other diseases, even beyond COVID-19, increased severity if they get to be sick, and we will also see a loss in GDP because of the burden on healthcare system, the burden on the education system, and the burden on the workforce. Karen, does that answer your question? You look like you have a follow-up one.
Yes, but we're not taking follow-ups. As you can see, we are going to go beyond the 4 p.m. We have another 15 minutes. So, and we want to do a poll as well, a new poll. So let's go to Asia, to Nepal. Marty Logan, are you ready? And then we're going to do the poll and take some more questions. Marty, in Nepal?
Yes, I'm here. Can you hear me?
Yes.
Okay. Thanks very much. Here in Nepal, we're on our second multi-sector nutrition plan. I think about halfway through, but the numbers are not improving. From the latest data that I've seen, the decline in stunting is now plateauing, and the last official figure on wasting saw it actually reversing and wasting increasing again. So you mentioned at the start of your presentation that some countries in Africa as well had seen this problem of a slowing in the decline of stunting. And I'm just wondering, has anyone started to identify some reasons across regions why this is happening, why the improvement is slowing down considerably?
Yeah, there are many reasons why improvements are slowing down in different contexts. So an action plan or a policy document alone will not lead to the implementation of appropriate interventions that will see the numbers that we want to see going down. To see those numbers going down, we have to implement these things at scale, the interventions stipulated in this action plan. So we have identified a few drivers of successful implementation of action plans. One of them is political commitment. And in many governments, political commitment is usually demonstrated through endorsement of the plan or signing of the plan without allocation of resources to that plan in a concerted manner. So to hold politicians and governments accountable, signing and endorsement of development plans must be accompanied by allocation of resources for implementation of that plan to demonstrate ownership and accountability. The second one is coordination. Most multisectoral programs are hosted by one institution. In countries like Ethiopia, Kenya, Malawi, Zambia, nutrition sits in the health sector. In countries like Mozambique, it sits in the agriculture sector. And so the custodian of this multisectoral action plan has no power and mandate to implement interventions included in that plan beyond the sector. And so it is really coordination of a truly multisectoral nutrition plans. It is not so much where it sits, but the fact that there's a coordination platform that will ensure that all sectors are called to action. And it needs to sit with a government department that has sufficient political clout to call on all the 11 sectors with actions in that plan to work. If we continue having multi-sectoral nutrition action plans sitting in the health or agriculture department, they will only implement their component of the plan. And what we are saying is that nutrition is a multi-sectoral issue that requires multi-sectoral action. The third one is actually data and ensuring that sectors not only know what about nutrition they should do, but how they should monitor what they do in those sectors. And a repository of that information using existing surveillance systems in a manner that can consolidate progress, like was done in Peru, for example. So a plan and intervention is one thing, but there are other drivers that are usually overlooked that we need to look at more critically as we move forward with implementation of these plans to be successful.
Thank you.
Thank you. Now, Marta, you kindly agreed to give us 15 minutes of your time. Can I ask for 2 more minutes? We would like to do the poll now and then have your concluding remarks. Is that possible?
Yes.
Thank you so much. Yes, so then let's do the poll now. It's a Zoom poll, so you'll be able to vote on the screen. And this is a journalistic poll, let's say. Your editor assigns you to do a story about child malnutrition in the post-pandemic. Which topic would you choose? One choice only. Stunting, wasting, obesity, vitamin and mineral deficiencies, chronic hunger. So let's see. So the topics are stunting, wasting, obesity, vitamin and mineral deficiencies, and chronic hunger. we'll give like a few more seconds. And in the meantime, Jerry, would you like to say some words while we wait for the results of the poll?
Yeah, I would love to say, I just put a comment in the chat section saying, what a wonderful, excellent presentation, Martha. You've given us so much to think about. You've given us so much information that I think the journalists can really use in the production of their stories. So thank you so much. I hope that I think there are always questions after these sessions. So I wonder if you might be willing to answer a few questions that come in by email later if we contact you with them.
I'll try.
Thank you so much. You've been
I don't know everything.
You know a lot. Thank you.
Paul, can we see the results of the poll? So here it is. So the winner is chronic hunger with 31%. Then vitamin and mineral deficiencies, 29%. Stunting with 21%. Wasting with 10%. And obesity with 10%. Martha, do you have any comments on this?
It's very interesting that chronic hunger has been selected, and chronic hunger has to do with all the other four. So chronic hunger will lead to stunting if it's prolonged. Chronic hunger will lead to wasting if it's short-term. Not necessarily obesity, but the drivers of under and overnutrition are similar, particularly in Africa and Southeast Asia. We eat a lot of starch and carbohydrate products, which fills our stomach but does not provide the nutrients that we need. So the child will be undernourished and the mother will be overweight or obese. And chronic hunger is also driven by the lack of all kinds of foods, including vitamins and minerals. So looking at chronic hunger would actually look at different ways that malnutrition is manifested, over and undernutrition at the same time, as well as the many drivers of malnutrition that we have talked about and the many interventions that we have talked about across sectors.
So thank you so much, Martha. Thank you to all the journalists who have contributed in such a lively and active way. The chat is really on fire with thank you and appreciation. It's really wonderful. So I will pass it now to Taylor for the final words.
Thanks, Mercedes. Special thanks to Martha and Nyagaya for a really timely and important presentation. Mercedes, thank you for guiding us. Thanks to Paul for technical support. Next week, we'll have on Tuesday, June 29th at 9 a.m. Eastern Time, we'll have Will Moore, the CEO of the Eleanor Crook Foundation. He'll be speaking on Nourish the Future, Approaches to Ending the Malnutrition Crisis.